Good evening, everybody. We'll just give a moment to let everybody make their way in. How are you, Dr. Kramer?
I'm good. How are you?
Good. Happy Thursday night.
Happy Thursday. Nice to see you, as
Nice to see
always.
you. This is going to be an awesome presentation. So with that, I know that there are quite a few people already here and some making their way in, but I'll get started because I know you have a lot of amazing content to cover. So welcome tonight to Wu University. I'm your host, Dr. Jennifer Stewart. It's my great pleasure to introduce Dr. Elise Kramer. She's a residency trained optometrist in Miami, Florida, who specializes in ocular surface disease and specialty contact lens design and fitting. Her doctorate degree was awarded in optometry from the University of Montreal in 2012. During her fourth year, she completed her internship in ocular disease at the Eye Centers of South Florida and went on to complete her residency at the Miami VA Medical Center. Her time there included training at Bascom Palmer Eye Institute, the nation's top eye hospital. After her residency, she became a fellow of the Scleral-Lens Education Society and now serves as a vice president for the SLS. She's also vice president of Women in Eye Care, a member of the American Optometric Association, the International Association of Contact Lens Educators, a fellow of the American Academy of Optometry, and of the British Contact Lens Association. She has published several important articles and reviews and participates in clinical research trials. She enjoys lecturing all around the world in several different languages about ocular surface disease and specialty lenses. She's a Wu Yu favorite, also a Wu Yu moderator, so she spends a lot of time here on Wu Yu, but we always enjoy learning and hearing from you. So with that, I'll turn it over to you.
Thank you so much. Such an honor to be here. These are my financial disclosures, and all financial relationships have been mitigated. And so I'm just going to jump right into this, and thank you everyone for being here again. So we're going to focus a little bit on contact lens dropout tonight and how that relates to eyelids and ocular hygiene and ocular surface. So the causes of contact lens dropout are frequently misunderstood and underestimated. So little is actively being done by the average practitioner to avert the situation. And it's true because when we have a patient that leaves our practice, they don't call us up and say, hey, Dr. Kramer, I'm not going to come back anymore. They honestly just leave. And we may notice down the line, we may not. And so, and if they stop buying contact lenses, they also may not tell us until the next year when we ask them, hey, like, I see that you've been wearing contact lenses. And then they say, no, I stopped, but we would have never known if we never asked. And perhaps they just won't come back. So we don't really know the actual number. And again, this may be very much underestimated. Like I said, what are we really doing to prevent contact lens dropout? The economic impact is also underestimated. The economic impact on a practice is rarely measured, and it's kind of hard to measure, right? And be far greater than the practicing optometrist perceives. How much do we get per patient per lifetime in a contact lens? This could be as much as $24,000 over the lifetime of a single patient who drops out of contact lens wear. So I don't think this is negligible. I don't think that I think this is important to talk about. And this is really what we're going to be talking about tonight is contact lens dropout, contact lens discomfort, why this is happening, and how do we prevent this by focusing perhaps a little bit more on eyelids. So when we look at this chart, which was published a while back in 2010, but still super relevant, and we look at the number one reasons for contact lens dropout, we can see that comfort and fit is really at the top, 50% in the US. And we see that vision, which is maybe what we would think it was, right? People are not using contact lenses anymore because perhaps they're not seeing as well as they once did. Could be they're now over 40, and so they're having trouble seeing up close. But no, it really is comfort and fit. And so some people think, okay, maybe people are dropping out of contacts because now they're so expensive, or because, there are a lot of daily disposables, but expenses is really not up there compared to comfort. What about application removal? So some people are scared of touching their eyes. Some people are have difficulty taking out their lenses or not taking them out properly, but this is really only representing 7.2% in the US. And again, we're talking about vision, bifocals, trifocal, or multifocal lenses now, or they're inconvenient to wear, or other reasons. This is really not as important as comfort. Again, half of these patients in the US are dropping out of their contact lenses because of comfort and fit. And so what actually causes contact lens discomfort? So when we look at, different ocular surface diseases like meibomian gland dysfunction, anterior blepharitis, it could be demodex blepharitis, dry eye syndrome, allergies, right? Dermatological conditions, or the contact lenses themselves, like the material, the fit, the way the actual lens is fitting on the eye. What we also know about these various conditions is that they actually interact with each other. For example, we know that people who wear contact lenses have a little bit more meibomian gland dysfunction. We know that anterior blepharitis and demodex blepharitis kind of sometimes are there simultaneously. We know that meibomian gland dysfunction, anterior blepharitis, demodex blepharitis are all things that could be underlying causes of dry eye syndrome. We know that allergies can happen concomitantly at the same time as dry eye syndrome. We know that dermatological conditions such as rosacea can also cause meibomian gland dysfunction. So a lot of these conditions are interacting. Contact lenses can exacerbate evaporation, which then causes more tear film instability, which then causes more inflammation, which then causes more dry eye. And so a lot of these things are just interacting together and causing more contact lens dropout from discomfort, right? So when we let's look at allergies, because I think that, allergies are underdiagnosed as well, affecting 20% of the population. Symptoms, itching, redness, swelling, which that could be for anything, but honestly, unless we flip the lid, we don't really see allergic conjunctivitis. So it often concurs or happens simultaneously with nasal symptoms, and it can significantly impact the quality of life. If a lot of the time, if I don't ask a patient if they have allergies or if their eyes are itching, they will not mention it. And I'm sure this happens to you as well. If you have a patient in the office and you're asking them like, how are you? How are you feeling? Good, great. Let's move on. Let's get my vision checked. Let's get my prescription and go. But if we say, hey, are your eyes itchy? How are you feeling with the lenses? A lot of them will say, yeah, sometimes my eyes do feel itchy, or lately I have allergies and this is bothering me. But it doesn't happen if you don't ask. So a lot of the time it's underdiagnosed and therefore undertreated. Only 10% with symptoms actually seek medical attention. So people are coming to their annual visit, but they're not necessarily coming in because their eyes are itchy. This is just kind of a thing that maybe, again, they would not have mentioned if you didn't ask. Most manage with over-the-counter medications and complementary, like non-pharmacological remedies, like cold compress or other things that they can come up with. But honestly, it's all about flipping the lid. And I tell everyone that when they have a contact lens patient, and even arguably a non-contact lens patient, just throwing it out there, let's flip lids on everyone. It does not take a long time. And honestly, it is crazy how much inflammation you can see here. And it does not always coincide with how the patient is feeling. It's not always a linear association. And so I've had patients who will complain of a little bit of itching, and then I will flip the lid and see a ridiculous amount of inflammation compared to how they're actually feeling. And so this needs to be addressed, and this can certainly be a cause, and sometimes the only cause, right, of contact lens discomfort and dropout. And so this is the first kind of eyelid thing that I wanted to go over, because I think it's, again, so important to flip the lids. It doesn't take long. You can do it with a Q-tip. You can do it with your finger. There's also different tools now that are available that make it super easy. So definitely do this. But moving on, right? So let's talk about where else discomfort can come from. And we know that dry eye is a big one. The thing with dry eye is it's such a vast condition that can be caused by so many different things that you really have to narrow it down. And so this is the TFOS DUES 2 chart, which I absolutely love because it really just separates dry eye for me in a very kind of logical way, where we see patients that are, okay, if they're symptomatic and they have signs of ocular surface disease, then we find out what the underlying cause is and then we treat it. But if they're asymptomatic and they have signs, then perhaps they're not dry, perhaps they have neurotrophic. And, we've talked about neurotrophic keratitis and other talks on. Honestly, we can have a whole talk just on neurotrophic keratitis. But there's other times where there are no signs, but then there is a lot of pain, and that would be more neuropathic. But let's go to the classic patient that's symptomatic. They're uncomfortable, let's say, with a contact lens, right? They have signs of ocular surface disease, which we'll get to. And then, so we're diagnosing them with dry eye. Now, dry eye, excuse me, dry eye can be caused by an aqueous deficiency. It can be evaporative or it can be mixed, right? And it's our job to discover what is the underlying cause of the dry eye disease. Now, most of the time, in fact, 70% of the time, it's evaporative. So this is what we're going to focus on, because evaporative has everything to do with the eyelids. Excuse me. Woo, gonna have some water. So if we look at the eyelids, okay, and we look at what actually causes evaporative dry eye means that the tear film, we're producing enough tears, but it is evaporating more quickly than it should be. So the quality of the tears are not there. And a lot of the time that's caused because of what we see here. This is classic meibomian gland deficiency, or meibomian gland, the toothpaste sign is when we see turbidity in the secretions coming out of the meibomian gland. So the meibum, it should be liquid, it should be fluid, it should spread over the ocular surface and prevent evaporation of the tears. But in this case, we're seeing how difficult it is for that meibum to come out. And what that causes is tear film instability, because you don't have a smooth layer of lipids over the ocular surface, and therefore the aqueous layer is evaporating too quickly, which causes a release of inflammatory mediators, which then causes more tear film instability, which then causes more inflammation. And it is a vicious cycle that if we don't interrupt it, it will perpetuate. So we see various photos here of the toothpaste sign, and it is something that you can easily see at the slit lamp. But if you don't do like manual meibomian gland expression, there are actually a couple of tools that you can use. So this is the meibomian gland evaluator, which you see up top. And basically what it does is it actually looks at the quality of the meibomian gland to make sure that they're open and patent. So it's very different than pressing on the eyelid and seeing what comes out. The meibomian gland evaluator is something that will just check to see if the meibomian gland is open and releasing oil. Whereas using your finger and manually expressing the gland will show the quality of the meibum that's coming out. So very different. The top one is a little bit more qualitative, the quantitative, where it will show the different number of meibomian glands that's actually patent and working. Whereas the image on the bottom, the video on the bottom, will show the quality. So it's more qualitative of the meibum that's coming out. And then there's other ways of evaluating the meibomian glands. So we see here meibography on the top left. So this is a test that I do a lot in my office, and it's amazing for educating patients. And so there's various different ways that we can image the meibomian glands. And essentially what we're doing is we're using infrared light to image the meibomian glands, and then you can actually show this to the patient. And so the old school method was actually using a transilluminator, like you see in the top right photo. But you can see that we have different devices now available on the market. And the bottom one, the MyBox, is actually really cool because you can just hook it up to your slit lamp and do it right there in the exam chair. But there are other devices you can use. And I think that just like the dental model, when we take photos of cavities, when we go to our dentist and they show us different photos of our, the status of our teeth, of our cavities, it's so educational, allows us to see and understand the condition. Meibography really allows us to understand the condition of our meibomian glands and also to understand really what's going on with our tear film. So it's not only good for me to understand what's going on in the patient eyelid, it's so important for the patient to see it and understand it, because then they really are game with the treatment. They really understand why we're recommending a certain treatment. And this allows them to really be on board and understand, because a lot of the time we're explaining things to patients, but if they don't see it and understand it, they may not, be compliant with therapies. They may be skeptical about it. They may not think, this is relevant. So showing these images is a game changer. And again, it really all starts with patient education. So education is everything. And one of the campaigns that I really, really, really like is the Look at the Lids campaign, which is honestly really looking at the eyelashes. And this awareness of eyelashes and deposits and collarettes is something that is becoming so mainstream. And this makes me so happy, because now we have treatments that we can use, and just asking the patient to look down on a slit lamp exam, which takes even less time. I was talking about flipping eyelids, averting eyelids. This takes a fraction of the amount of time that takes. So this is a 2-second test where you ask the patient to look down, and the things that you'll see, it is just so, without trying to use a pun, eye-opening, because it really changes everything. And when you see something like this, it really needs to be addressed. A patient could be dropping out of their contact lenses because they have something like this going on. And honestly, if you're the doctor that asks the patient to look down, which again takes 1 or 2 seconds in a slit lamp examination, and you find this, and you actually find something to treat this, and you allow a patient that's always wanted to wear contact lenses be comfortable in their contact lenses, you're going to be their doctor for life. Not only that, but they will bring you their friends, their family. There's so much we can say about a happy patient, or versus a patient who would drop out of their contact lenses because we didn't find something like this, because we didn't ask the patient to look down. So let's talk about demodex blepharitis. What is it? Demodex blepharitis is a common eyelid margin disease caused by an overgrowth of demodex mites. Overgrowth is a nice word. Infestation is another word that you can use, but overgrowth is a great word to use with your patients. I think choice of vocabulary is very important when we're educating our patients, but between us, we can definitely cause this an infestation. It's characterized by collarettes, eyelid redness, inflammation, ocular irritation. It's highly prevalent, okay? Even though we think, oh, demodex is rare, it is underdiagnosed. It affects 25 million eye care patients in the United States. That number is huge. Like if we think about the number of patients who got cataract surgery last year was 3 million. This is 25 million. This is huge, right? So demodex folliculorum is 0.3 to 0.4 millimeters in length and colonizes the base of the lash follicle. So that's how we can really see it. Demodex brevis is different. It is 0.2 to 0.3 millimeters in length, and it colonizes the meibomian gland. So there's actually 65 different parasites that exist, or mites that exist. Okay, but only 2 actually live on humans. And these are the 2. One is demodex folliculorum and one is demodex brevis. Because we're focused on eyelid health, we are going to focus on demodex folliculorum. Collarettes are a pathognomonic sign of demodex blepharitis. Pathognomonic means that when we see a sign, it is directly related to this condition. It cannot be anything else. It is used to diagnose this condition. So if you see a collarette, it means that the patient has demodex. Like back in the day, we thought that we had to have microscopes, that we needed to epilate a lash, put it with fluorescein in a microscope and check to see if there was a mite. Now, most of us do not have microscopes in our offices, and rightfully so. But honestly, all you need to see is a collarette. 100% of patients with collarettes have demodex blepharitis. Collarettes are cylindrical dandruff. They're translucent, solidified excretions that form this cylindrical collar that cuffs around the base of the eyelash follicle, as you can see in all these photos. Collarettes grow out of the lash follicle and thus are anchored at the base of the eyelash with its growth. Collarettes are composed of, now, I hope none of you are having dinner. Collarettes are composed of regurgitated, undigested mite waste combined with epithelial cells, keratin, mite eggs, and secreted proteases and lipases. But this is real. It's gross, but it is there. And if you ask your patient to look down, you will see it. And in these images, you can really see the difference between a patient looking straight ahead, and you can really see what happens when the patients look down and you expose the collarettes. So asking a patient to look down during a slit lamp examination can reveal diffuse collarettes and misdirected or missing lashes that are a strong sign, again, of demodex blepharitis. Collarettes are hardened excretions around the base of the eyelash, which is visible during slit lamp examination. They can be identified when the base of the lashes on the upper lid are exposed and the patient looks down. So again, always ask your patients to look down, look at the lids. If we ask the patient to look straight, we are going to miss these things. And these are close-up images where you can really see the difference when a patient is looking straight ahead and the patient looks down. You can really see how we can identify this. And again, this is no extra time added to your slit lamp examination. So what does demodex do? There's mechanical, bacterial, and chemical things. So lash distension occurs as demodex mites attach to the follicle, and basically they will scratch. They come out at night, so they're actually regulated on the circadian system. So when we release melatonin, this causes the mites to come out, and they can scratch and cause microabrasions, which is just very painful and uncomfortable in the eyelashes. Demodex mites also carry bacteria on their surface and inside their gut, which can create an immune response. And along with their debris and digestive enzymes, they can contribute to inflammation in the eyelid margins and surrounding tissues. So they're just very irritating and can cause a lot of discomfort, redness. These are different things that you can see, comorbidities of demodex blepharitis. So in the first photo, you can see eyelash abnormalities, deposits there that maybe are not going to, are recurrent after cleaning, that they're just going to keep coming back. The eyelashes are distended. They're also going to be misdirected. You can see eyelid margin inflammation. So just like telangiectasia, erythema of the eyelids, and people are very subconscious about this. It just looks like they've been crying, that they've been rubbing their eyes, that their eyes are irritated. Conjunctival inflammation, and this is my photo. You can see redness of the bulbar conjunctiva. You can see corneal manifestations as well. Chalasia, where you obviously, the bacteria and deposits can cause clogging of the meibomian glands, which can then lead to infection of a meibomian gland, which can lead to an internal hordeolum, which can lead to a chalazion. So a lot of different things that can happen. So 59% of patients, let's say the prevalence of patients with dry eye is 59%. And 58% have demodex blepharitis, according to this study, where there was 1,032 patients. So the question is, we are documenting dry eye. We are saying, 59% of patients have dry eye. Are we writing in our charts that 58% of patients have demodex blepharitis? I don't think so. And that's what I'm saying. It's just very underdiagnosed. And the number of patients who have demodex is huge. As I mentioned, 25 million, right? So, and now we're seeing in this study, 58% of patients with demodex blepharitis. So majority of patients that we're seeing may have demodex blepharitis. And again, it is something that we can diagnose just by asking the patient to look down. And if we treat these patients and actually help them with this problem, we can have them perhaps be comfortable in their contact lenses and not drop out. Remembering that contact lens dropout, the number one cause was discomfort and fit. So in the Titan study, which is a study that I was just talking about, which was a retrospective chart review of 1,032 patients, collarettes were common. As I mentioned, 58% of these patients had demodex blepharitis. 51% of these patients were contact lens wearers, 56% had cataracts, 60% had dry eye treatments, 65% of these patients had glaucoma, 69% of these patients had blepharitis, and 57% of these patients had meibomian gland dysfunction. Now, why is this important to talk about the other conditions that they have or the other things that they have? Because these are patients that we're seeing. Depending on the type of practice you have, if or working in, if you're working a lot with contact lenses, look how many patients may have demodex, or if you're in a pre-op, post-op office, an OMD clinic where you're seeing cataract patients, 56% of these patients may have demodex, according to this study. Blepharitis, and if you're working in a glaucoma practice, 65% of these patients in this study also had demodex. So just because they're coming in for a different reason doesn't mean that they don't have demodex. So again, a lot of patients come in and they don't necessarily talk about how they feel or their discomfort or their itching unless they're probed with questions. And they might be coming in because of their cataract, they might be coming in because of their contact lenses, of their glaucoma. And so always check for demodex as well. It's so common. The Atlas study, which was a multi-center observational prospective study, evaluated the clinical and patient-reported symptoms of demodex blepharitis. 55% of these had itchy eyes. Now, I talked a little bit about allergic conjunctivitis, which itching was also one of the main symptoms. So you can see how there can be masking of different conditions, or they can exist together, right? So it's really important that just because someone has itching, that we don't automatically assume that it's allergies. They could also have demodex, or they may just have demodex, right? 46% of these patients have dry eyes. So again, dry eye is a vast topic. It could be aqueous deficient, it could be evaporative. What is the underlying cause of the dry eye? Is it demodex? Is it blepharitis? Is it meibomian gland dysfunction? Is it all three? Now remember, a lot of these conditions can exist together. 23% of these patients had foreign body sensation, 21% had watery eyes. And so these are symptoms that we are encountering very often. And these are different things that should push us to check for demodex blepharitis. So what is the impact of demodex? Well, 47% of patients feel that, or their eyes, that they just are conscious of eyes all day. I think that's a big one. Like, people don't want to think about their eyes. They just want to do what they need to do. They want to work out. They want to go to work. They want to spend time with their families or their friends. They don't want to think about their eyes. 47% of patients with demodex are feeling their eyes, they're conscious of their eyes. 47% of people are having difficulty driving at night that have demodex. 34% difficulty wearing makeup. I'm sure you all have those patients that say, I just don't wear makeup anymore. I can't do it. Every time I wear it, I can't, my eyes are irritated for 4 days. I have those patients. And so the question is, okay, but why? Like, why can't you wear makeup? Like, what is, outside of like being allergic to the actual ingredients of the makeup, what could be causing this reason? Are these the same patients that are dropping out of their contact lenses, right? Additional time needed for daily hygiene routine, of course, and 80% of patients reported a negative impact on daily activities. So this is extremely relevant. Look how many patients, the prevalence of demodex is 58%, and 80% of these patients are reporting negative impacts. So this is not negligible, and it's something that needs to be addressed. So again, in this study, 51% experienced symptoms of blepharitis for 4 years or longer. So that's a very long time. 33% reported 2 or more visits to eye care providers for their blepharitis before receiving a diagnosis. So they had to come back multiple times. And honestly, if they come and you just give them artificial tears, or you say, it's going to go away, it's not a big deal, we'll just change your contact lens material, but it's really demodex, then they're going to keep looking for an answer because it doesn't just go away. 81% of surveyed patients with demodex blepharitis sought some form of treatment. So people are looking for answers. They will look because people don't want to live with this and feel this way on a daily basis. And 80% reported that demodex blepharitis, again, had a negative impact on daily activities. So we talked a little bit about patient education. So what can we do to address evaporative dry eye? So there's different things. Obviously, we talk about hot compresses at home, artificial tears, nutraceuticals, eyelid hygiene. This is all very basic and should be done for everyone who has evaporative dry eye to help, improve meibomian gland function. Other things is, different things that we use for eyelid hygiene. We know that soaps are not ideal. Baby shampoo, definitely not. It honestly will obliterate the lipid layer, because when we look at soaps, when we look at baby shampoos, these are soaps. So they're getting rid of lipid layer, which is counterproductive in a patient that has evaporative dry eye. What we're trying to do is we're trying to promote the lipid layer, right? So the last thing that we want to do is get rid of it. And these soaps and a lot of people are still recommending this. And I see some patients who are still using baby shampoo to clean their eyelashes and their eyelids. So this is something that should be avoided at all costs, because again, it is going to get rid of the lipid layer, which is something that we're trying to maintain and we're trying to improve. So what about eyelid massages? Cleaning with massage has been shown to be more effective than just cleaning alone. So there are a number of techniques for eyelid massage which help express meibomian gland. So if we just do a hot compress, a lot of the time it's not going to do much for the meibomian gland or to release the oil. We're liquefying the oil because we're raising, we're melting that oil by putting heat on it. But if there's no massage, then the oil might just sit there and solidify again. So the massage should go from the root of the eyelid to the margin using a warm compress or gentle pinching action on the eyelid again, as you see in this photo. So it does help release the oil. And then different active ingredients that we talk about for eyelid hygiene. So hypochlorous acid, which has shown to be an effective treatment for killing bacteria and controlling biofilms around the eye. It can also help with allergies. So for our patients who also have allergies, and Avanova pioneered the use of hypochloric acid with stable and pure solutions around the eyes. And then there's just hydration wipes, which help reduce dry skin associated with itching, irritated, inflamed eyelids. These contain hyaluronic acid, glycerin wipes, such as iMed Pharma's Eyelid and Lash, like you see here. These are great for hydrating dry, sensitive skin. And then, the tea tree oil, it is toxic to demodex. It does help, but I don't know if you've ever used tea tree oil. For me, it does burn a lot. I've had patients complain of burning. I've used it myself. It does burn. And, there are a few formulations with tea tree oil. And before, this was one of the only treatments that we had for demodex. And so unless people use tea tree oil, there wasn't really a way that we could, address the demodex. So these products are formulated with 4-terpineol from tea tree oil to eliminate demodex mites on the eyelids. And we did talk about the fact that demodex also travels with bacteria. And so, using hypochlorous acid might help with the bacteria, but unfortunately, it doesn't really have much of an effect on demodex itself. And then we have these devices that we can use at home, like the new lids device, which is used to like a toothbrush, very analogous. But what we do with it is just put this little gel on it and use it to clean the eyelashes or the eyelids and remove deposits. So again, if you're removing deposits, it's going to work. But if you're not treating the underlying cause of these deposits, then they can just recur. But prior to having some treatments that we have now, this was one of the only ways to remove deposits that were accumulating in the eyelashes and around the eyelids. And so there's different ways of using this device. You could use it with the eye open, with the eye closed. It is safe to use. Some patients really like it. And it works to remove deposits again in the eyelashes. And then we talked about hot compresses. The procedure differs depending on the products that's used. So you want to use a cloth that's not too hot. Obviously, we don't want to burn the skin. And it should be held against the closed eyelid for about 5 minutes. And that will help also loosen scales on the eyelid margins and improve fluidity of the meibum again. But hot compresses are not the best treatment. It's not very well standardized. There are new eyelid warming devices which provide constant and controlled moist heat therapy. So the thing that happens in meibomian gland dysfunction is you have a solidification of the oil. Inflammation causes the melting point in the meibum to increase, which prevents it from coming out of the meibomian glands. And so what we do with a hot compress is we raise that temperature, melting the oil, and allow it to come out again. The thing is that if we use a hot compress that we warm up at home, whether we're using a microwave or whether we're using a hot cloth, what happens is that the temperature rapidly decreases. So it will stay hot for a minute or two, and then after that, it rapidly decreases. There are other treatments that I'm going to show you that maintain that heat for a certain amount of time, and they will control the heat. So obviously you don't want to overheat either. Another thing is that hot compress will heat up the entire eye, so arguably can also raise inflammation. Whereas a lot of the devices that we have now can actually direct heat exactly where it needs to go and avoid heating the entire eye. So it's definitely works better. And there's several different devices that we can use for meibomian gland function. So we've got the MeiboFlow, the LipiFlow that you see on the top right, the Tear Care device, which you see on the bottom left, and then IPL also, which helps with telangiectasia. It also stimulates the meibomian glands. So a little bit different with IPL, but also working on meibomian gland function. So these devices, again, are going to be better controlled than the hot compress because they provide a controlled amount of heat exactly where we want to direct it for the amount of time that is specified to do so. Where, again, a hot compress will have a rapid decrease in the amount of heat after a few minutes and also heats up the entire eye rather than just the meibomian glands. So let's talk about new treatments that we have now. So again, demodex was like the party that the mites are having in the eyelashes and on the eyelids. And lotilaner, which is a new type of drop, will eradicate and completely kill these mites. And lotilaner has been used for years in mange in animals. And it works so well. And it's the first time that it's really available in an eye drop, and it is the only FDA approved treatment for demodex blepharitis. So there's no contraindications right now. If more than one topical ophthalmic drug is being used, it should be administered at least 5 minutes apart. And again, not to use with contact lenses, of course, but it's 1 drop per eye twice daily, 12 hours apart for 6 weeks. It's a great treatment. It has a beginning and an end. And it really, really works to just get rid of the mites and get rid of the collarettes. And it's used for 6 weeks to also interrupt the entire reproductive cycle of these mites so that we don't have more mites coming once the collarettes. Because again, a lot of the treatments that we're doing, like the new lids device that I showed you, like the eyelid hygiene, microblepharoexfoliation that we do in the office, all these things will get rid of the collarettes, but they won't necessarily get rid of the actual mites or the mites recurring. And so we can see the Saturn 1, which was the trial that was done with TP-03, which is lotilaner, that the complete collarette cure was grade 0, no more than 2 collarettes, and clinically meaningful collarette cure was grade 0 to 1, no more than 10 collarettes. And you can see the primary endpoint was reached for both of these. And you can see that in this photo here, what it looked like before and after the treatment, and just the health of the eyelashes. You can see how much healthier they look when they don't have collarettes stuck to them. They're nice, they're smooth, they're not misdirected, and this can have a huge impact on contact lens comfort. So when we talk about, what we can do in patients, contact lens dropouts are not obvious in most practices. Again, patients are not going to come up to us and tell us, hey, by the way, I've decided not to use contact lenses anymore. They will tell us this if they come back and if we ask the right questions, but they may never come back and they tend to just fade away. And they do account for a significant loss. So it is relevant to talk about contact lens dropout. And again, the main cause for contact lens dropout is not vision. It's not expenses. It is discomfort. So we play an important role in helping patients persist with routine eyelid care. And eyelids have a huge impact on contact lens comfort because evaporative dry eye is such a big cause, or one of the main causes of dry eye itself. And dry eye is a big cause of contact lens discomfort. So it's all related. The importance of evaluating the ocular surface, including the eyelashes, the eyelid margins, to assess for meibomian gland dysfunction or demodex infestation in contact lens wear is very important. I showed you how to assess meibomian gland dysfunction. Again, you can use the meibomian gland activator, evaluator. You can use your finger to express the meibomian glands and look at the quality. And you can look at the meibomian glands using meibography. And again, this is such a great tool to educate your patients as well. For demodex, it's even easier. You just ask the patient to look down, and that's how you see the collarettes. So just asking a patient to look down. If you are a contact lens practitioner, you work with contact lenses, a lot of the time you are already asking your patients to look down to look at that that top edge of the lens. But if you're not working with contact lenses a lot, just ask your patients to look down. Again, it takes 2 seconds and it can change the entire exam and the entire treatment plan and protocol for your patient. So better management of the ocular surface could reduce contact lens discomfort and potentially improve retention of contact lens wear. So think about it. If you address the eyelids, then you're addressing the tear film. And if you address the tear film, then you're preventing discomfort in contact lenses. And therefore, you're getting more patients to stay in their contact lenses. And that's what it's all about, right? So if you're a practice owner and you're trying to generate revenue from contact lenses, or even from contact lens exams, if you get your patients to be comfortable in their contact lenses and maintain that comfort, then you will have a happy patient, and a happy patient will bring their friends, their family, and they will keep coming back.